this is the last disease that you need to know under obstructive pulmonary diseases, and that is bronchiectasis. So like any other disease, first definition. So the name says itself, bronchiectasis. Bronchi refers to bronchi and bronchioles. Ectasis comes from ectasia, which refers to dilation. That is, there is permanent dilatation, ectasia, of bronchi and bronchioles. So which part of the respiratory tract is affected? Bronchi and bronchioles. What is happening to bronchi and bronchioles? Ectasia. There is permanent dilation. Just break the word into two. Bronchi and bronchioles. Ectasia, ectasis, ectasia, dilation. So there is permanent dilatation of bronchi and bronchioles. Now why is it that these tubes, they have dilated? It is because the wall of bronchi and bronchioles have become weak. Why is it that there is weakening of the wall of bronchi and bronchiole? Because there is a destruction of parts or portions of wall of bronchi and bronchiole. Why is it that there is destruction of wall of bronchi and bronchiole? Probably because there is inflammation. So the final thing that you need to remember is that there is damage to wall of bronchi and bronchiole. As a result, there is weakening of wall of bronchi and bronchiole, and as due to which there is permanent dilatation. All right, so there is damage to wall of bronchi and bronchiole, weakening of wall of bronchi and bronchiole, and then permanent dilatation of bronchi and bronchiole. Now the question is, how does this damage occur? What are the causative agents of this damage, or the etiology? So here is the etiology. There are three major etiological factors. Number one, congenital, that is by birth the child might have something called Cartagena syndrome, which is strongly associated with bronchiectasis. Number two, acquired, later on in life there might be obstruction in the tube or infection that leads to bronchiectasis. How? See, obstruction, it can be due to the formation of tumor within the tube, or maybe formation of tumor or compression from outside. All right, infection is infection. Then immune disorder like rheumatoid arthritis, SLE, inflammatory bowel disease, or lung transplant rejection. Pathogenesis. Now the way the disease develops depends on the etiological factor. For example, if we are talking about Cartagena syndrome, Cartagena syndrome has its own triad, which consists of number one, bronchiectasis, number two, sinusitis, and number three, situs inversus. What are the three things? Number one, bronchiectasis, number two, sinusitis, and number three, situs inversus. Another important thing about Cartagena syndrome is that in Cartagena syndrome there is something called a primary ciliary dyskinesia. What does this mean? See, your whole respiratory tract is lined by respiratory epithelium, right? Which is the ciliated pseudostratified columnar epithelium. That means there are these tall columnar cells which have cilia. These cilia, they beat in a rowing motion. If you take out one cilia and look at its composition, you can see that it contains something called the dynein arm. In Cartagena syndrome, there is dynein arm defect, and due to dynein arm defect, the cilia loses its ability to move. That is why dyskinesia, that is there is dysfunction in the kinesis or motility of cilia. Ciliary dyskinesia, cilia dysfunction kinesis. There is dysfunction in the kinesis or motility of cilia. Since it is due to Cartagena syndrome, it is primary ciliary dyskinesia. Alright. There's also male and female infertility. Male infertility because the flagellum of the sperm, it is non-functional. Female infertility because, see, the fallopian tube, it is also lined after all by ciliated simple columnar epithelium, and the cilia, it becomes dysfunctional, non-functional. As a result, it is unable to beat and transport ovum. So there is female infertility. Second, so What there are many etiological factors as I explained, but the most common etiological factor that leads to bronchiectasis is obstruction and infection. During obstruction, let's say this is your bronchi, there is obstruction due to tumor. What happens? There is continuous production of secretions, but then these secretions, they don't go down. As a result, there is pooling of all these secretions. There is pooling of mucus, pooling of serous fluid, all of them. They continuously exert stress on the wall of the bronchi. As a result, there is inflammation. On the other hand, infection leads to inflammation. Either way, be it obstruction or infection, there is inflammation. Due to inflammation, there is damage of the wall, which leads to weakening of wall and permanent dilatation. Gross. What did I say? What is bronchiectasis? It is the permanent dilatation of bronchi and bronchioles. So what do you expect to see in gross? The dilated bronchi and bronchioles. What else? So you can see dilated bronchi and bronchioles. Now, depending on the shape of the dilation, there are various types. You have varicose, you have cylindrically shaped, radish-like fusiform, or saccular. But the important thing that you need to know is that these dilatations, they give off a peculiar appearance, and that is honeycomb appearance, which is most commonly seen in left lower lobe, where LLL, in the left lower lobe. You can see right here, there are many dilated bronchi and bronchioles, and they give off the honeycomb appearance. You can see right here as well, there are these dilated bronchi and bronchioles that give off the honeycomb appearance microscopically. So I said earlier, there is pooling of secretions. The secretion contains mucus, so there is pooling of mucus. So in lumen, what are you going to see? You are going to see mucus. There is infection leads to pus production, and that's why pus in the lumen. So there is mucopus in the lumen. Second, the mucosal lining or the mucosa, it gets ripped off, or you get slurred mucosa. There is mucosa, then it becomes discontinuous, then mucosa, right? There is discontinuity in mucosa because part of it has been ripped off, slurred off. Then bronchiectasis. What happens in bronchiectasis? Inflammation happens. What happens in inflammation? Inflammatory cells come. So you can see lots and lots of neutrophils throughout the thickness. Lots and lots of neutrophils. You can see right here, there's the slurred mucosa. So what are the three major things? Number one, mucopus in lumen. Number two, slurred mucosa. And number three, inflammatory infiltration. Clinical feature. So a 40 years old male presents with history of 2 years, quite a long history, of productive cough, that is cough with sputum. And the peculiarity of this sputum is that it is extremely foul smelling. So with foul smelling sputum, recurrent fever, given is the bronchial biopsy and X-ray. In bronchial biopsy, you are able to see the slurred of mucosa, and in X-ray, you are able to see a peculiar appearance, that is tram track appearance. So these are the tracks, these are the two tracks of the tram track arranged parallelly. Similarly, the bronchi and bronchioles are also present or visible, arranged parallel to one another. So that is the tram track appearance. So clinically, the patient presents with, most importantly, foul smelling sputum, and upon X-ray, the presence of tram track appearance. In chronic cases, there might be amyloidosis as well. So that's it. One last revision. Bronchiectasis. First, definition. Bronchi referring to bronchi and bronchioles. Ectasis comes from ectasia, which means dilation. So there is permanent dilatation of bronchi and bronchioles. Number two, etiology. So there is congenital etiology like Gardner syndrome. There is acquired etiology like obstruction and infection. And then there is immune disorders like rheumatoid arthritis, SLE, inflammatory bowel disease, and rejection of lung transplant. Pathogenesis, which is dependent on etiology. If you are talking about Gardner syndrome, then there is primary ciliary dyskinesia due to dyne arm defect, which leads to pooling of the secretion and inflammation, weakening of the wall, and bronchiectasis. If we are talking about obstruction and infection, again there is pooling of the secretion, there is infection leading to pus production, inflammation, weakening of the wall, and bronchiectasis. Then grossly you can see dilated bronchi and bronchioles, which give off a peculiar appearance called honeycomb appearance, which is most commonly seen in left lower lobe of the lung. Microscopically, three things: mucopousin lumens, lot of mucosa and inflammatory infiltrates throughout the thickness. Clinical features: the patient presents with foul smelling sputum. Upon X-ray you can see tram track appearance, and in case of chronic cases there might be amyloidosis. And we are done with bronchiectasis, or shall I say we are done with complete obstructive pulmonary diseases. Next up we are going to look at pneumoconiosis, the three major types of pneumoconiosis: the cold worker pneumoconiosis, silicosis and asbestosis.